Afternoon. Welcome. This session will be recorded. We have the privilege of having here today a real expert in malaria control. Professor Jean Louis Ndiaye, I'm pronouncing it correctly? Yes? He's a professor of parasitology. He's from Senegal. He has appointments both at the University of Dakar and Thiès. And I just recently read some of his papers, 4 of them, including one in +1. Very impressive work that he has been doing with this seasonal malaria chemoprevention. So I'm very excited to have Professor Jean Louis here. The idea, Jean Louis, is that you speak for about 30 minutes, and then we will be asking you some provocative questions, and then we will open to the public. Is that correct?
Correct. Could I respond in French to the question?
French, you can Spanish, you choose your language. So please join me in welcoming Professor Ndiaye.
Thank you, Director. I'm very pleased and very happy to be here. So I really like to thank Michel Rowe, Michel Chang, and all the team at the UCSF for inviting us to spend these very, very wonderful days since Monday. So very thankful again. So I'm here just to present a kind of overview of the SMC story when we started from the WHO recommendation. I mean, SMC started 20 years ago when we just started research, trying to find new strategies to prevent malaria illness. So I'm just maybe from 2012 up to now. So this SMC is a project funded by the UDCP. It's optimizing seasonal malaria prevention in Western Central Africa in collaboration with the London School, with the WHO TDR, MMV, and also 13 SMC implementing countries in Western Central Africa. So the outline of my talk is what's going on? So as an outline, I'm just going to go a brief introduction, talking a bit of malaria in Africa, but also showing what is the role of SMC and what is the implementation status. And after we'll go through the different SMC projects in Western Central Africa before going to final words, final conclusions. Because I have this screen working here, but yes, okay. So as you all know, that malaria is a very dangerous disease from like centuries before even Jesus Christ was described already. And it's due to 5 species of parasite. We have like 120 parasites in the species of Plasmodium in the phylum of the Apicomplexa. And it's a protozoa parasite. So 5 are really responsible of the disease: Plasmodium falciparum, Plasmodium malaria, Plasmodium ovale, Plasmodium vivax, but also Plasmodium knowlesi. But the most killer of the children, of African children, is, as you all know, Plasmodium falciparum. It's responsible for more than 90% of the cases, and because of it's also responsible for the cerebral malaria. That's why the reason why, I mean, the main cause of why it's killing children. And you all know the parasite normally is someone who's not wanting to kill you. He wanted just to live with you. And when he started to killing you, it's because, I mean, there's a problem with the interaction. So we're going to see, as you see in the slide, that those 5 parasites differ in geographical distribution, clinical features, patterns of drug resistance, and epidemiology. So very, very complex epidemiology. This kind of triad is between the host, the human, the vector, the mosquitoes, Anopheles and Anopheles gamblia, which is very complex as well, the parasites, and all in an environment, and there's many factors which are contributing to different interactions. So we can see that here there's many factors who's involving and who are also contributing in that disease in terms of where the people behavior, urbanization, the treatment, access to care, but also the waters, the climate, the temperatures, those many factors. That's why malaria is still here. Just to briefly, maybe it's for the students, probably you all know this. This life cycle with the three main component and the different cycle when after just the mosquito bite for the blood meal, 100 of parasites, the sporocytes are going to the liver when they will be hidden for like 2 weeks before going to the blood cells, and a lot of interaction in the invasion of the blood cells, and this is when the disease are coming from, and when the way they are trying to escape is to transform the parasite into gametocyte, male and female, and going to the mosquito. So this is very quickly a kind of just reminder of the life cycle of the parasite. So complex, diverse antigenic variation, diversity in genetics, and so many other factors that show that malaria is still there. So if you see that in the last 20 years, progress has been made in the malaria control. So you see the decrease from 2000 to 2015, and a lot of commitment of the funders, the implementers, the health system, the research parts. But since a couple of years now, the progress have been stalled, and we see now the increase of cases from the two or three last years. There's more than 50 million. More than 15 million cases increased from 2019 to 2020, and also increase in deaths. So that's why we need very innovative strategy. That's why we need to really be more aggressive in our malaria control. And that's why these strategies have been really not created, but we not created the wheel, but we refurbish a bit the prevention. Before we are using chloroquine, but with the problem of resistance. Now this is the seasonal malaria chemoprevention. It tends to be an intermittent administration of two drugs, sulfadoxine-pyrimethamine and amodiaquine, effective during the peak of the transmission season. So this is mainly for the seasonal areas. So you can see here the peak of the season, and it's very intended to the
so otherwise I'm interested in still not.
Sorry. Yeah.
See how this goes for now.
Thank you. So this is the seasonal malaria chemoprevention definition, and the area are really you can see the central and central part and the western part of Africa. These are really the seasonal area, the area where the malaria 60% of malaria occurring in 4 months, and 60% of rain also in around 3 to 4 months. So these are, and SMC has been proven to be very effective. This is one of our studies showing more than 80% protective efficacy, both in under 5 and in 5 to 10 years old. So the recommendation from WHO will really recommend SMC in the under 5, but here in Senegal, where I'm coming from, we are the only country now implementing SMC up to 10 years, because we saw that the burden of the disease and the deaths are also in the 5 to 9 years old, as shown here. When we compile the data from 2012 to 2016, all the SMC area, this is showing, you see here from 5 to 9 years old, you see a lot of cases of death. And when we look at the implementation through 4 or 5 years, we see that SMC is really effective at reducing by 40% the malaria deaths in hospital in southern parts of Senegal. So SMC is really a community-based intervention. It's driven by the community and the health system. It's the door-to-door campaign. It's found to see the best approach using community volunteers, using community health workers to go to the household and treat the children, so the children under 5 or under 10 years old. It's using the very effective drugs, there are 2 old drugs, SP and amodiaquine. And at the beginning, it was very difficult. We don't have the pediatric formulation, but now we have 3. I mean, just last week, you have the 3rd one coming. 3 manufacturers now are able to produce dispersible tablets and with a test market. So it's really improved the compliance of this treatment. So it's a 3 days treatment given during the 4 months or 5 months during the peak of the transmission. So the first dose is given directly observed treatment by the community health workers, but the home dose, the 2nd and the 3rd day of amodiaquine are given by the mothers. So it's really important to explain to the mother the reason why these children have to take that pills, how the effectiveness of it, and to follow, you need to follow up, and that's why we are giving them a card. You see here, the mothers or the caregivers are getting cards. We need to follow up to see exactly who is tracking the treatment and why it's effective or not effective. That's really important. And I'm gonna just briefly show you how we're monitoring SMC programs within our group. So there's different factors that can influence the impact. Here you see the delivery and administration is very, very, very important. So we need a proper planning, training, supervision, and the coverage as well. So we need to be sure that using a very method of measuring the coverage in order to measure really the efficacy with the cases, and finally getting the impacts. And so several considerations also to measure for the delivery, for the coverage, but also for the efficacy. And WHO just released a new protocol for chemoprevention. That was a gap. There was a lot of protocol for using the therapeutic drugs, but for the prevention there was a gap. And we developed several studies on case control methodology and so. But now we have a protocol. I think we need maybe to just think if it's really working or not. So showing you quickly how we work with the country to really increase the scaling of this program. It's really started in 2014, so 2 years after the WHO recommendation, with 2.5 million children covered, 7 million in 2015, 15 million. From 2019, we have like almost 20 million. And in 2019, we have like 20 million children covered, more than 85 million treatment given, but there's still a gap. There's still a gap on the eligible children who can benefit for this treatment. And that's why we Opt SMC went through and have been proposed to the funders and funded. And now we are at 2 years of the implementation of Opt SMC. Of course, there's a lot of coverage and implementation gap where you are seeing that countries don't have reliable estimates of who really took the drugs. Not all children are getting full treatment. We do have a lot of problem. One, in the household, you give the pills to the mothers. I mean, if there's another child sick, they'll preferably give to them. If the child also vomit or have some adverse event, they will not give the second or the third treatment. There's a lot of problem in that treatment. And also we have some high coverage in some countries like Burkina Faso, but in many countries the coverage is very low. That's why we built this consortium of named Opt SMC, really to try to strengthen the capacity of the National Malaria Control Program to help them how they can better deliver the SMC drugs, how they can improve the access, and how they can monitor also the delivery to evaluate impact, how they can target the high tourist population, the nomad. We have very mobile population in Africa, but also how we can promote inter-country collaboration. We are not all at the same level, so some countries are more experienced than the others. So this is the project, and the objective is, as I said, really define the research priority, helps the country to develop implementation research proposals, a project, and to address the research priority, improve SMC, and to conduct a priority of what is in country priorities. Just briefly to show, when we at the beginning of this project, we start with all the countries from Senegal to Chad, though the 13 implementing countries, asking them where are your priorities for you? What do you think about is the priority? You can see briefly, sorry, it's very small. I wanted to put all in one slide. So there's an implementation issue, but also some capacity building need and skill to be really strengthened. These are, we're gonna go into detail about these different projects. And the way we wanted to, we work since 2 years now is really how we can identify the barriers, understand the barriers and the facilitators, how we can identify strategy to overcome those barriers, and to optimize the facilitators, implement strategy, evaluate strategy, but also inform the SMC implementation policy. That's really our objective in this program. And you can see from now, these are the countries who said that this is my area of interest. So Niger, Togo, and Chad are saying that just they want to adapt to the target group. They want to know who are really susceptible to develop severe malaria, where and when should we target the strategy. So when is the peak of the transmission? So Guinea, Mali, and Cameroon wanted to develop new strategies because what they are doing, they're seeing that lot of problems. Ghana wanted to know about the coverage survey. They are not sure that they are really reaching all the populations. Benin doubting about really the efficacy of the SMC. So we developed with them a case control study to show if it's effective or not. In Senegal, you know, the WHO recommendation, the treatment was 1 dose directly supervised, and the second and the third dose not supervised, given by the caregivers. So with the problem we saw in Senegal, we decided from 2019 to give DOT 3 times. Each cycle, the 3 doses will be directly given by the community health workers, and we want to know if it's really cost effective. But at MCP, they are sure that it's cost effective, but we as a researcher, we don't think that it's really cost effective, because when we are conducting the operational research, we saw it very, very costly. So this is what Senegal wanted to implement. Guinea-Bissau, Togo, and Niger, they want to see the SMC impact. And all countries want to really analyze better the IGHS data, district health information system, the way they are collecting the information, and to know how to better interpret to see if there's an impact or not. And some qualitative study also has been undertaken by the Guinea, Niger, Burkina, and the Gambia. So I'm going to go quickly to country by country. The main results, what they found with the Ghana coverage, they found a high coverage of 92% in all cycles, but some barriers, including the lack of time for callback visit to non-responders, some side effects. So side effects is really one of the bottlenecks. With the amodiaquine, it's really bitter and giving some abdominal pain. But usually when the mothers just realize that it's really effective by preventing illness, so they can, I mean, they are more confident with that drug. So the cost of the side effect management as well, because we are giving the tablet to those children who are not sick, and if the parents have to pay to go to the health clinics, that could also be a kind of barriers. And this work has been presented last year to the ACMH Tropical annual meeting. The Benin case control studies, we help them to really recruit the cases and the controls, and now the analysis is ongoing. Probably in the next coming months, we'll have the results of the efficacy of this trial in Benin. Niger, so wanted to, like Senegal, target the 5 to 9 years old, but they need some evidence on that. So we are helping them to really collect disaggregated data, individual data in the health clinics to be assured that you have the burden in the older age range. Senegal, as I say, we're planning a cost-effective analysis of SMC, but also modeling work to see what is the best approach. Chad, we are still discussing on them with Chad and Guinea-Bissau about the proposal they're going to implement. So the Guinea one, it's a very interesting one. We have a 2-phase studies. The first one was really to see, they observed that in the mining area in Sigiri, they have very low coverage of the SMC. They wanted to see why. So with some qualitative survey we've conducted with them, so they discovered that a lot of barriers. And the second part of the study was to implement some solutions. And that what they do, so they try to reduce the workload by increasing the distributor of the medicine. They select those available throughout the second, but also they select those who are coming from the community. That was a barrier because people were not confident with these guys coming from another region coming to give them pills to their kids. And by strengthening also the community mobilization, they really ended up with an increase of the coverage. So a bit more costly in that region, but maybe if they have a good advocacy with the funders, they could now really scale up this strategy. It has been presented last week at the ACMH. The Guinea one also is very qualitative to see the barriers as in Guinea, as in other countries, and they see also what are the problems and what are the solutions, and probably they will implement it in the next SMC season. So it has been also presented last week. So some studies are still ongoing in Burkina Faso. I'm going to go just quickly. This was just to give you an overview of what is going on in this country. So Burkina Faso wanted to evaluate, as say, the determinant of poor SMC coverage. Togo is looking also at who are really the most susceptible children to receive the SMC. And the Gambia wants also to look about the adherence. So they really dubbed about the adherence of the SMC doses. So Mali also is another interesting one. They want to do as Senegal, but they want to promote another strategy. So the standard one is, as I said, giving the 1 dose by the community health worker and the 2 home dose by the mothers. So they want to compare that standard dose with the SMC with the direct observed treatment 3 times at each cycle, at each treatment, compared to the one where they will gonna have community volunteers coming each night to just remind to the household, to the mothers, to give the drug the day after. So they will compare this. It's still the study is still ongoing, and in Cameroon also want to really investigate effectiveness of using household leader to improve the adherence. So adherence is clearly one of the challenge many countries are facing. So now we see that in 2020, the number of children has really increased up to 35 million. And you see that, I mean, Nigeria is one of the main providers of this SMC treatment. And the last one is just one. This one we're going to release maybe in a couple of months with the World Malaria Report, showing that now we have 45 million children treated in 2021 with the SMC drugs. And you see that country are not now adapting their strategy with the epidemiology. So there's countries who are now testing the 5 cycles, though others are doing 4 cycles as the WHO recommendation, and others are giving 3 cycles. And this is a new things that bring us to really show you how we can adapt, how we can decide of what is the optimal number of cycles and what is also the optimal start. Because if you start so early, you will miss a lot of cases. I think you started early in June and you finish in October, maybe you'll have a lot of cases. If you have late also, the strategy does not work. So to really increase the impact, you need to define what are the optimal start, what are the optimal number of those. So we investigated in Senegal. So I was the PI of this study. These are the 4 regions where we are conducting SMC in Senegal. Tambacounda, Kolda, and Kédougou. And we conducted a sentinel surveillance with a probably proportional sampling, choosing 32 health posts, the 12 hospital and 3 regional hospitals, collecting disaggregated data, the SMC data, and the catchment population. It showed in 2018 that malaria in Senegal, in southeast of Senegal, is still hurting the children from 5 to 9. Oops. So I'm showing the second graph with the 5 to 9 years old. There's a lot of malaria occurring there in Kolda, in Tambacounda, and not in Seju. So Seju, they stopped the SMC because of the low prevalence. The effectiveness has been also confirmed with this study, showing that the average reduction of cases under 10 in the health facility associated with the SMC distribution was 60% during the 21 days from the start of each cycle, and 56% during the 28 days after the treatment. So showing that really important to give a treatment after every 4 weeks. But what is really interesting to see is giving the number of cycles you have to conduct in each country, in each region, you will see that you can have a greater impact or not. So meaning that if you have to conduct 5 cycles in Kedugu, you have to start in early June. If you have to, currently it's 4 cycles, so you really start in July. So we are really orienting the NMCPs to choose the best time and also to choose the best number of cycles. And these are one of the results we've got, and we're gonna now do it in the other country to help them really optimize their SMC. And one of our main results of this study also to see how we can prioritize the regions. For example, in Senegal, we saw that, I mean, the transmission is really highest in Kedugu, so we need to think about implementing 5 cycles in Kedugu first before thinking about doing SMC in another regions. And this is the model who gave us that with the work with the London School, showing that we need to start in Kedugu first before going to Kolda, before implementing in Tamba, and no need really to do a 5 cycle in Tamba, and no need to do SMC in Seju, because here you see that the curve is really flat. So these are really the work we are conducting with 13 countries, and now our future plan is to see how we can integrate our SMC work with the vaccine. So we have a vaccine. That's the first time we have the vaccine against a parasite really working. I mean, it's not really working. It's not the best vaccine you have, of course, but I mean, we see that, I mean, we can use it as a very, very effective tool if it's combined with other strategy, but also if it's given in a seasonal areas. So that's where the idea came to combine SMC and the vaccine and to do a seasonal vaccination. Just to show you that this figure on the top is the SMC, how SMC is covering the 4 months of the peak of the transmission. And this is the vaccine. And when you combine SMC and the vaccine, you ended up with 70% reduction in malaria deaths, 60% in the reduction in the incidence, and 70% also in severe disease. So this is really huge, and it's very, very promising results. Unfortunately, there's not enough vaccine currently, but we are working on that. I mean, we probably need to increase the production of GSK in Belgium, or find another producer to really increase the number of available doses. So how countries are asking, a lot of countries are asking, so there's the vaccine, we want the vaccine, but they're asking how they're gonna implement it. The best figure is to include it in the API. It will be more cost effective, but we need to think about how. And you know, with the results we have, with the several trials we got, it's really difficult to have those one not recommended before 5 months. It's not working. So the vaccine has its high efficacy after the 3rd dose. So 6 months after the third dose, you have very high efficacy, but after that, the efficacy is really waning. So that's why it's important maybe to give the 3 doses before the peak of the transmission. So you have the high effectiveness during the full 6 months, and have a booster a year later. So option 1 is through the API, but it's not really optimally timed unless born in the right months. It's not. The option 2 is really having the seasonal campaigns for each dose, but here as well, maybe you're gonna miss a lot of children. So really the option 3 we are proposing is to do our best to give the 3 first dose as early as possible during using the API, and the 4th by campaign, and using a seasonal campaign, the 4th and 5th and maybe the 7th during the 5 years, and we'll have the best maybe figure and having more results. So high efficacy rate probably will not be having with the option 1. So option 3, which is really hybrid one, will be a very, very good option. That's why we are telling to the countries. But there's still a lot of implementation challenge. You see that there's the children, naturally is half of the children survive in that area. So probably, Gavi, I don't know who is going to provide the vaccine. They need to balance where they should put the available vaccine. For sure, the 3 countries that are implemented the vaccine, Kenya, Malawi, and Ghana, will be the top priority for WHO. But here also we have to think about this. The second one is the coverage of the API. We have many countries where the DPT3 coverage is very low. Where you have the high transmission is where you have the lot of the vaccine coverage low. So we have to think about it. And the third challenge is, as I said, we're gonna maybe give to the 3 countries first before giving to them. An example also is in Nigeria, where in northern Nigeria, you see that there's even many areas where even there's no vaccine. So that's another challenge of giving this seasonal vaccination. So some key issue to be taken into account is the careful evaluation in the first country and inform the others, use the lesson learned, including some piloting with the alternative delivery methods, strategy to promote the uptake, and lot of communication, lot of sensitization, because with the social networks, with social media involved, it's very quick. You can destroy a strategy very quickly if you don't have a good or proper way of communicating with these communities. They are aware of everything going on, so we really need to do an effective and important communication, and maybe that vaccine against malaria could help to improve the coverage of the vaccine, because due to just how the malaria is felt by the communities. So I'm going to conclude this to say that the optimal timing, as we show, may vary from year to year up to 1 month, 2 weeks, by region to region. So programmatically, it could bring some challenge, but country should be able to really make a good shape of their SMC using the data they have in country. So the impact also could be improved substantially by just optimizing the number of cycles, depending on the peak of the transmission, depending on the onset of the rain and the offset of the rain as well, because malaria is linked to the rain season. And we want also to push the boundaries. So we want to increase the areas where we are going, want to increase the age range. So if the 13 countries are going all up to 10 years old, we reach about 80 million children to be covered. So so it maybe can create a big impact. And there are new countries coming. Mauritania have started this year. Nigeria will want to go further down. And we have also Mozambique, Uganda is now also having some implementation, SMC implementation program. Combining SMC with transmission blocking drugs, with seasonal vaccination, with monoclonal antibodies should be carefully planned, designed, and evaluated to really demonstrate the impact. That's really important. And finally, the commitment of the NMTP in these projects, the community engagement, but also the collaboration with the research partner is essential for success factor of our program. And I would like just to finish by thanking you again. Thanks some people who contribute to the fund, but you for your kind attention.
Thank you so much for a really fabulous lecture. I enjoyed it immensely. Michelle, would you join us here, please? You can stay there so that we continue with the recording.
Cesar is also remote if you want him to join.
So we have a
Okay, great.
wherever you want. We also have a student online, Cesar, that will be perhaps asking questions. He has read all of your papers.
Oh, yeah.
So I'll invite Michelle also to ask questions here. I have several. One around the malaria vaccines. You did mention RTSS and how these two interventions could be, in fact, complementary. Now, what can you tell us about the new Oxford vaccine? Is that showing promise? Will that move RTSS away, or how do you see the new Oxford vaccine? And can you tell us also a little bit about cost effectiveness of each of these interventions?
Yeah, I mean, the AirTurn1 is the one by Adrian Hill groups in Oxford, and it has been implemented in Burkina Faso with a team in Nanoro with Alido Tinto. So it's a very, very promising vaccine. I mean, the good thing is it's quite the same vaccine with RTSS. It's a pre-erythrocytic vaccine. They just showed up 80% reduction, but it has been, I mean, depending on the way you are analyzing the data, I mean, if you evaluating the impact just after the 3 doses in the highly transmitted season, you will have that efficacy rate. But we need to see it, I mean, for a longer period of time. But in any case, I think it's very promising, and using it as also seasonal vaccination would be another very good thing. And probably the good thing is they're saying that we will have maybe more doses available because the GSK has a very limited, GSK is they have a very limited capacity of production. Now, I think from the next 2 or 3 years, they're planning to produce 15 million doses, which is quite nothing if you compare to those children who need the doses and how many times they need the vaccine. So yeah, probably it's a good one. Though the RTSS seems also very, very expensive, but I mean, ACTs also were expensive at the beginning. So we need maybe to just do some fundraising because it saves lives.
And Gavi is supporting RTSS.
Yeah, exactly. Yeah. I mean, for instance, I think the RTSS cost $5 per dose, I think. And you have to give it 3 times and with the annual boosters, and the operational cost will be also very heavy. So yeah, definitely the cost will be driving probably. And that's why maybe they will target the 3 countries. I mean, country will have maybe small dose, but we need to think about where we're gonna put it.
Michelle.
Well, thank you, Jaime, and thank you, Jean Louis, for a really excellent talk and for coming all the way from Senegal to share your experience and expertise with us. And I just want to congratulate you and thank you for all that you've done in SMC and malaria, just the evidence you've generated in your leadership and bringing together partners from all over so many countries to kind of collectively address this challenge. So just a few questions. One is like SMC was scaled up so quickly from like 4 to 20 million children covered in like just a few years. And it's just really remarkable like that scale up could happen. I'm just curious to hear, what do you think, what factors really facilitated that sort of really huge scale up? And then since the age range that's been covered is going up to 10, I'm just curious if the risk is now in like older children, if you're starting to see that in some of the countries where they are covering up to age 10. And then I have so many questions, sorry. I'll just ask one more, is just regarding the consortium where you're supporting countries to do research. I'm just kind of curious to hear the experience. I mean, the programs will come with the right questions, but they may not have like the research skills to design the study the right way to answer the question. I mean, not all people in programs. So how do you support that for that particular project and beyond? And I know that's within the scope of like the grant for this consortium, but that's maybe a bigger question. Like, how do you build capacity in programs to do program evaluation?
Yeah, thanks, Michelle. I mean, for the first one, I think what was really critical is the collaboration between the researchers and the Ministry of Health. So we build up since, I mean, the long tradition in Senegal and in other countries, but Senegal was quite a leader on that. So when we just have the first results of the SMC trials, we start working with the programs. And we had a network, the RBM network, which is regrouping all the West African countries. So we used to go to those meetings and present the results as they were coming. So the program were really aware of what is going on. So that's why when just the WHO recommendation went in 2012, they already started looking for funding and how to implement. And during the first phase also at the implementation, we did a lot of country visits among us to go to see how we can really help them to develop the guide, to implementation guide, how to train their medical doctors, their nurses, and that's why I mean it's that create that synergy, and I think that's the reason why it works properly.
I think the link between the research and program.
Yeah, that's really the one most critical, I think. And what we are saying is where in countries where the research is not well developed, so the program is not well performing. Yeah.
Can I bring
That's the first one. The second one was about the age range. Yeah. I mean, the thing is, the template country are using to see to collect the data is under 5 and over 5. So it's really difficult to see among the over 5 groups where is the burden. So I mean, we just ended up very randomly. I think one of the first trial we are collecting the data that how we found that the 5 to 10 years old are having like 3 times more malaria cases than the under 5s. It's may due to the shift in the epidemiology. It may due to several other factors. But that's what we found, and we are just at the first year of that large implementation scale up. So we just ethically we just wanted to go to the up to 10 years old. That was in 2009. So we did 3 years of operational research in that groups. That's why when the WHO recommendation came, Senegal had just have enough results to go. And the WHO was saying at that time, so we're not going to recommend this because you are the only country doing that. So we want to see more more papers on that. So we are seeing Mali, Burkina coming up, and maybe at that time also there was not enough drugs, so they didn't want it to increase the demand. But now it's a really a demand for many countries. And yeah, even in the Gambia, they're seeing cases up to 15 years old. So that's need to be think about. But some modeling done by Matt Ken show that, I mean, you are increasing the impact. I think I have some extra slide. Maybe I can show it to you. You increase the impact when you're going up to 10 years. And we even have an indirect effect on the transmission. But when you're going up to 14 years, the effect is much less because you have that much cases, that much severe cases or death in the teenager from 10 to 14. And the last one about capacity building, yeah, this project is a coordination of strategy action. So we developed several tools with the WHO TDR to like conduct a need assessment survey and several workshops on how we can help them to write proposals, to analyze the data, and also even to write the papers. So it's they're really enjoying to work with them. Maybe the problem is the turnover, because it's a kind of politic position. They are moving a lot, but otherwise, yeah, it's quite successful.
Thank you.
We have a student, Cesar Mendez, online. Cesar, go ahead.
Hi, can you hear me?
While Cesar is getting connected, I have a question for you about the formulation. I saw in the slides, mothers have to crush the pills and they're bitter. Is there an infant formulation that would be liquid or more profit for little babies? That is one. And this different question is, have you thought of using the community health workers delivering the drug to also deliver other chemoprophylaxis for like fluoxetine for trachoma, or oral rehydration therapy, or albendazole for as an antiparasitic, just to make it more cost effective as a package of interventions. Have you thought about that?
Yeah, I mean, the first question about the pediatric formulation, that was really at the beginning, from 2013 to 15. That was really bitter drugs and non-dispersible. But from 2016, we have now the dispersible tablets, but not the syrup, but you can put it in the water and it disperses properly.
It dissolves.
Yeah, it dissolves. Yeah, and it's taste make market. So, but some countries are adding a bit of sugar to be to help the children to take it. So, and for the second one about the distribution by the community health workers. So in many countries, you have that mass campaign of distributing albendazole, praziquantel, ivermectin for the NTDs. So I mean, fully agree with you. We need to think about how we can integrate those treatment, integrate those preventive therapy. So I've just a trial now going on how we can better, in the same platform of chemoprevention, using the SMC, and during the SMC, giving praziquantel or albendazole. Maybe if you invite me next year, I will show some results.
You are invited. Okay, let's see, Ashley. Okay, please.
All right. Linnea says, thank you for presenting this important work with us today. It's a really interesting, multifaceted project. My question is maybe similar to yourselves, but how did you manage to get each country to focus on those priorities in the table? And how do you manage to make yourself accountable to each priority request?
Yes, thank you. It's very important question. It's could be a sometimes nightmare to really work in the country. So I mean, we ended up with when you have several research groups, it's much easier, because I mean, you see maybe at least one will be friendly with the NMCP, so we can build on that and to work with the NMCP. But when you have only one, that's where you have the problem. So in Niger, for instance, that's a problem. In the Gambia, that's really the problems. But in other countries, it really works well. And we see the Guinea and Nigeria and Ghana, they almost done already the project, because the Guinea, the NMCP coordinator was coming from the research field, and they just identify one social scientist to help them. So they were really the lead on that. That really worked pretty well with the Nigeria group as well. And the Ghana, I think that the program who wanted to do the coverage survey, so we really trained them and they did it. So in some groups, they really wanted to do some implementation research because they're seeing the results. But in others, it's a very challenging, and sometimes also they're selecting some area which for us not really a priority. So we really help them to focus better. So they have a bunch of priorities, a bunch of research questions. Well, but we need help to see this is really what you need to think about. And there's the last one. Oh.
I brought one more. The second question is, how do you build community health workforce capacity? You
Yeah.
mentioned some are volunteers. Will they receive any additional training, skills, compensation for their time?
Yeah, I mean, this is also, I mean, I think you mentioned that. So it's a really another problem. So we have, I mean, our health system in Africa is really relying on those community health workers, but these are informal groups. These are not well recognized. Sometimes they are not paid, or we really challenge to get them paid. So how to really formally train them, how to really integrate them in the health system is a key to build out on the sustainability of all these programs. So we are trying, we have a network, we are trying to train them. I mean, you have some network who are sometimes working on malaria, sometimes on HIV and on several other diseases. So we try really to make it, how to say, more formal, but still a lot of challenges.
We have time for one or maybe two quick questions from the audience here. Please.
It was really interesting to hear about the different SMC research interests among countries. And I saw that all of them want to study further UCSF too. They all listed that as one of the research interests, right? So I was just wondering, are there already salient challenges across countries in chapters or salient successes?
Yeah, I mean, each country also has, they are not all at the same level. Some are very perfect since using that since several years now, and those are just starting. We want to work with GMP to create a SMC module on the DHIS2, and also to see how they can better interpret, because in many countries they're saying that, I mean, we're implementing SMC since many years, but we see case increasing. So, and there's several reasons why the case increases. So if you increase if you implement the free access to care, you will see a lot of case coming in. So if you, I mean, there's an interest on really interpreting the DHIS2 data, and probably we'll conduct a workshop very soon with WHTDR and the GMP to help them to do that.
All right. Well, that was a fabulous lecture, Professor. Thank you so very much. And you're definitely invited for next year.